I'm be participating in this debate and focusing on the MRD-driven therapy for CLL. I think the main benefit of MRD-driven therapy is that it's individualized based on response to by individual patient to individual therapy, and then we can focus towards the duration of therapy. But I would trying to argue that when we take a patient-focused approach and determine the duration of therapy, rather than arbitrarily saying everybody should get fixed duration therapy, then we can improve the outcomes for our patients further. What I will try to show in this data set is that especially for high risk or intermediate risk CLL patients, the MRD-adapted approach probably will be giving better results than fixed duration approaches, and still better than continuous therapy. So the fixed duration therapy would be still appropriate for patients with low risk disease. And when we're talking about IGH3 mutated CLL patients, as well as patients with 13q deletion, this might be an entirely reasonable option because these patients are going to do very well with fixed duration therapy. Where my argument comes down to is the high risk patients, where we are defining therapy, very effective therapy, but we're choosing the length of therapy by just using a stop point, which I don't think is right in my opinion. In my view, the evidence is pretty clear, and we've got a very strong phase 3 trial, which has already reported out, though it was an academic study, one from UK, showing that MRD-adapted therapy is superior to continuous therapy in terms of progression-free survival and overall survival. The complicating factor has been and has always been that MRD-adapted approach needs technologies and availability of MRD to be done in clinical practice. But in my view, the evidence is there. And the next steps really are looking at a number of other phase 3 trials, which are looking at MRD-adapted approaches to be showing, which hopefully will show the similar results what we have already found in our studies.